When you were in physiology, did Robin talk to you about Fitzpatrick scale of the skin types, 1 through 6?
No.
So I will send you guys a slide then. It's just basically, and you can look it up in Harrison's, but it's just a Fitzpatrick type, and it's type 1 through 6, I believe. And it's based on your hair color, skin color, those kinds of things that put you at risk for skin cancers. So basal cell carcinomas are the most common type of skin cancer, and you guys will see this a lot. You'll see it in your elderly patients. You'll see it in your young patients, your 20s and 30-year-olds who've had a lot of sun exposure. The one thing, if I were to choose out of all 4 of those diseases, I would want a basal cell, just because it grows really slowly. But usually they're like a superficial papule or nodule, and it usually comes from the epidermis. And so sometimes it's hard to tell between the difference between a basal cell and a squamous cell because they both have the same characteristics as a lesion that doesn't heal. That just, you scratch off, it rescabs, reforms, and it just won't go away. And the one nice thing about basal cells is they rarely metastasize because it takes them so long to grow. But having said that, I've seen many cases where basal cells, they've let it grow and grow for decades. And it will take over, and it may not grow out this way, but it will grow deep into their sinus cavity, their eye socket, those kinds of things that it destructs the surrounding tissue and structures, the bone and all that. So it can get bad if they let it go long enough. But the majority of basal cells you will see will be on the head and neck. And it's mainly in the sun-exposed areas. So for men, it's usually the back of the head or back of the neck, behind the ears, and the tip of the nose. Men like to wear ball caps, well, most men do, but it doesn't cover all of this. So when you're out on the lake, floppy hat. It's not very cool looking, but it saves your ears, saves your nose, and saves your back. Because that's the majority of where I saw all of my patients is in those regions. Epidemiology, average lifetime is about 30% for Caucasians. It's greater than 2.8 million cases a year that are diagnosed. Most common in the elderly population, because if you talk to anybody who's older than when they were younger, they worked out in the cotton fields, they went around without any shirts, didn't have sunblock back then, and they spent their lifetime doing that, farmers especially. So you'll see a lot of these older men that come in with just things all over them, all over their head, face, hands. You don't even know where to start spraying because you'll spray their whole body. Again, most common in individuals light hair, light eyes, and that don't tan well. So my husband is one of those. He likes to say he's working on his base. And every time he says that, I say you're working on a basal cell is what he's working on. He's got blonde hair, blue eyes, fair as he can be. And so anytime I see anything on his face, I shove him to his dermatologist and they freeze it off or take it off. Because he is one of those people that, ran track, played tennis, played baseball, fished, all that outside without wearing sunblock. And he still runs outside without sunblock. He says it gets in my eyes and it burns. I was like, wear a sweatband or something, a hat or something. He's like, I look like a dork with a sweatband. So male to female ratio, men are twice as likely to get it than females. Risk factors, obviously UV rays, so sunburns, tanning beds, again, your Fitzpatrick type, and history of transplant. So a lot of these patients who have had transplants, their immune system is down. So again, you have these strange cell turnovers because they're immunocompromised. And then once you've had a basal cell, you're most likely going to develop another one. I see that time and time again. One patient, he has tons of them. I mean, he'd come in like once every 2 months with a new basal cell on his face, but he's like, 85. And then any areas of previous trauma can develop a skin cancer as well. And then these are just a few other diseases, xeroderma pigmentosum, again, skin type, and then alcohol consumption. And I thought, alcohol consumption, it's because those who drink tend to be out in the lake, be out in the sun, when you're out drinking, you just want to be outside. And so that puts you at a higher risk of getting a skin cancer as well. Just the pathophysiology, these come from the basal keratinocytes of the epidermis. It grows by direct extension, and it's unpredictable growth and progression. So, but again, most likely they really are slow growing. There's 5 different major pattern types, so I'm going to kind of discuss, but I left out that mixed pattern because I didn't go over that. But you have nodular, you have superficial, micronodular, infiltrative, and morphiiform, or mixed patterns. So what does a basal cell look like? So it's basically this shiny, waxy, pearly-looking papule. And it generally has what we call telangiectasias running through them. So they're kind of flesh-colored, dome-shaped, and has little vessels in them. Now, sometimes you can have one that has eroded in the center, so it kind of has like, almost like a little pit and some rolled edges. And in some of them, you can also have crusting. So in larger basal cells, it's kind of hard to differentiate between that and a squamous cell, just because they can be big, scaly, and actually could look like other things, like a tinea or a pityriasis, anything like that. And they generally are translucent because they're kind of clear, flesh-colored. And again, there's a telangiectasia. And slow growing, about 0.5 centimeters in 1 to 2 years. But I've seen really big ones that, like I said, took 10 years to grow. In our elderly patients, they like to put salve on it. I don't know where they buy the salve, but they all come with salve that they put on their lesions that they swear are supposed to take away the tumor. And so some of them, and now we do have chemical-based salve like that does it, but these is like a black salve. I don't know where they get it or get it off the internet, but half the time all it does is it just takes off the top surface, but the bottom cell layer is still there and it just continues to grow.
It's like a cream?
Yeah, it's like a cream. It's like a black salve. If you ever talk to any older people, ask them, do you have any black salve? More likely they'll have it in their drawer somewhere.
S-A-V?
Huh?
S-A-V?
Yeah, like a salve. Like a cream.
My SP
I don't
said
know
that
if I'm
once.
spelling that right.
It's like the name of it is that? It's pretty right.
Is it salve? Ointment. But they call them elderly people salve.
Yeah, my SP's like, yeah, put some salve on it. They call it, and then she called it tiger
You
balm.
say salve, but it's with a V.
It's salve.
S-A-L-V-E.
Sorry.
Uh-huh. And again, 85% occur in the face, head, and neck, trunk, extremities, and actually this where I got this from said not on the hands, but I see it on the hands all the time. Or maybe it's more AKs and SKs on the hands that you see them. I saw this a lot, periocular, we have a lot again, has to do with the blockage from the sun, but you get a lot of them at the under eyelid because you're hooded, but some of it is all left right there. Lower eyelid, and you have what's called your medial canthus, so right here, the bridge of your nose and the inside right between the eye. Upper eyelid, and then the lateral canthus on the outsides. These are bad because these, again, they would let it grow and grow until it starts pulling down their eyelid, then they have an ectropion. And then sometimes they let it grow long enough, it'll affect their facial nerve. So then they have an ectropion, a droopy face, and a big thing right here on their eyes. So the clinical types, the first one is nodular, and that's the most common type of basal cell that you guys will see. Again, this is the one that's more pearly, pink and white, and has dome shape and has the little vessels that run through it. And sometimes the inside may bleed. But again, you usually can see these, once you biopsy, it'll tell you that it's a basal cell. And so this is the one that kind of has that, see how it's kind of shiny and pearly looking, and then it has all these little telangiectasias in it. And this is one that more has that pitted, rolled edge look to it. Is that funny? Now you guys will all be looking at everybody, you look at your parents, you go home and check your significant other. And you'll find things, believe it or not. And then the second type is called a pigmented basal cell. And these contain melanin. So a lot of times these look like melanomas. So a lot of times they're mistaken for melanomas. And the only difference is that the melanoma aren't generally as raised and rough as these are. And then these are generally seen in darker patients, like so someone with darker eyes, darker hair, someone who has more melanin in their skin. Because yeah, this one definitely looks like more like it could be a melanoma. But see, it's kind of firm and it's raised. And this one has that central pitting like the other one has. And this is a cystic basal cell. So it's smooth and round. It behaves similar to a nodular basal cell, but it has more kind of, I feel like it's more round and more cystic appearing. And then there's something called sclerosing or morphiiform basal cells. They're waxy, they're flat, they're slightly raised, but they kind of have indistinct borders. They're kind of more, they're not as raised, and it just looks weird. Y'all just see them? See how it looks a little bit different? It still has that little bit of telangiectasia in it, but it's flatter. It doesn't have, that round domey appearance of that pearl. It has a little bit of pearliness to it. But it kind of looks like scleroderma. You know, scleroderma is kind of like a tightening of the skin, and that's what it kind of looks like. Ooh, look, he's got some suntan on his eyelids too. And the fifth one is a superficial basal cell. These are the least aggressive type. Usually occurs on the trunks or your arms, your legs, extends peripherally. They're usually round to oval shape, and you can have scaling. They're scaly plaque looking things. And sometimes sometimes they can be mistaken for an AK or actinic keratosis or even an early squamous cell. But they can also look like these things, like eczema, Paget's disease, psoriasis, because it has a little bit of scaly appearance to them. So this is what a superficial basal cell looks like. So can you see where that might look like a psoriasis or an eczema patch, you know? But they just look a little bit more red, and they don't, you know, with the psoriasis, you'd have a thicker plaque all across it. And tinea, you'd have more of a central clearing. You still have that kind of distinct border. But this is what I normally see as a basal cell when I see them all on patients. Again, they're usually on their hands and things like that. So those you'll want people, you know, to send them to the dermatologist, or you all. If you work in family practice, you'll have liquid nitrogen that you can freeze these lesions off.
Can I ask a question really fast?
Yeah.
So whenever you want someone to, like, if you saw this on someone and you wanted them to go get looked at, I've heard people say before that, well, it hasn't changed in like shape or border or anything like that. But would you still suggest them to
I
like?
would still suggest them to get it frozen off.
Yeah.
Yeah. I mean, now, if it's something that looks benign, that kind of, you know, that obviously doesn't look like something weird, that it could be a cancer, then you could watch that for a while if you wanted to. But those things look more flesh colored, you know, they don't have this red, weird appearance to them. And with eczema, you'd actually see them, you know, more on the flexor extensor, you know, those areas that you're looking for in eczema, if you're thinking it's something more benign. But it wouldn't, I generally would, if they have, especially if they have it kind of all over their hands and on their forearms, I usually send them to a dermatologist who keep a better eye on them, and see them like every 6 months and freeze them off. Now, the other thing you could do is you could measure it. Take a little tape measure, measure it, document it, you know, like on the left forearm, approximately 2 by 3 millimeter macule, erythematous macule with slight scaling. You could put possible BCC, eczema, something like that. And that way you document it, and so when they come back to see you, you can re-look at that and re-measure it and see if it's changed. Because sometimes when someone looks at something, they may not think it's changed because they see it every single day. But you who wouldn't have seen it for 3 months would probably notice if it grows, you know? Because you eventually get to know your patients, especially if you work in family practice, to where you're like, oh, yeah, that wasn't there last time you were here, you know? Yes.
When do you decide to do Mohs versus just freezing it?
So it depends on the patient and the location. So, we'll get to treatment with Mohs. I don't know if you guys know what Mohs are, Mohs surgery is. So basically you see them send them to a Mohs surgeon, and they basically sit there and they cut around and around and they test, they'll look at it under the microscope and see if they get what we call negative margin, so there's no more cancer. But, so basically, they just cut around till there's nothing left. But what's different between them and if you send them to like a dermatologist or a head and neck surgeon, they cut margins around. So when we would see them, we have at least, like a 2 millimeter margin around the outside where there's no cells at all, whereas a Mohs surgeon just stops where it stops. So it just depends on how aggressive the lesion is and how small it is. My friend actually in PA school, again, I used to call him the golden child because he was the blonde head, blue-eyed kid, he was the golden child of our class. And, I don't know, maybe 6 years after we graduated PA school, he found a little spot on his nose right here. And he actually went to a Mohs surgeon because he didn't want to have a scar there, because that's kind of a hard place. If you were to, incise or excise it, you'd have a longer scar. So that's another reason is if cosmetic-wise. So he had a Mohs procedure, and they cut out a pretty good chunk out of him. But again, the only bonus is that he can develop skin cancers more readily, but he has the type of skin that heals well. So you can't hardly even see that he had a scar there at all. And that's the nice things, I joke with some of my patients that come in and have to have big reconstructive surgery. So I'm like, well, the good thing is that you're gonna heal nicely. Like if I were to have surgery and have a Mohs procedure, I would probably keloid. So I couldn't do that. But like if Jordan had it, she would heal fine. You probably would never even see that it was there. So it just kind of depends. And this is something, I'm not going to touch on this, but it's called nevoid basal cell carcinoma syndrome. So it's a rare syndrome where you can have multiple basal cells at birth or in early childhood. I tried to find a good picture of it, but one picture I found of a man, it looked like he just had neurofibromatosis. And then on the hands, I was looking for good pits. It said pits on the palms and soles. I couldn't really find a good picture for you all. So, and then they will get cysts in their jaws as well. But it's really rare. So again, these are just some differential diagnoses, what some things can look like. You can have what are called sebaceous hyperplasia. You may see it in some people here, you may see it in your parents. They just have little bitty, little domes on their faces. And actually, if you take a little 11 blade and just nick it, you can actually push that little thing out with a Q-tip. Just some other inclusion cysts, nevi, molluscum. So can you see how a basal cell might look like a molluscum? So it's shiny, it's pearly. That's what the molluscums kind of look like. And nummular dermatitis, I don't think you guys have had that. Psoriasis, the melanoma, like we talked about, pigmented lesions kind of look like that. And atypical fibros, xanthomas, and rarely an adnexal neoplasm. And so how do you diagnose someone with a basal cell? A lot of times, eventually, if you guys work at a derm clinic or family practice, you'll be able to look at it and go, yeah, that's a basal cell. However, sometimes basal cells look like, or squamous cells look like basal cells, but they don't act the same. So if you got someone who comes in with this lesion and you see them back in 2 weeks and it's grown twice its size, then it's not a basal cell any longer. It's most likely a squamous cell. But you can do a biopsy, usually easily done in the office. You can do the shave ones like we showed, or you can just do a punch biopsy. So the punch biopsy with a little deeper tissue and tells you the depth of invasion. And usually imaging is not needed. Now, the only time we ever do a CT scan is when they come to our head and neck clinic and they've got big, massive, destructive basal cell that's invaded like their sinuses, their sinus cavity, their maxillary, and then we would do a CAT scan just to see where it is and how deep it is. And this is just a little FYI, whenever, I don't know, you guys will eventually look at path reports, but you'll see like something that will say well differentiated or undifferentiated. So usually well differentiated means you can tell what type it is generally, so that's better treated. And then the undifferentiated, it's kind of hard to tell the difference, if that makes sense. But don't worry about that one, it's just a little FYI for you guys. And then how do you manage these? So there are several ways you can take care of it. You can do what's called electrodesiccation and curettage. So these are the smaller lesions. You can get one of those curettes like Professor Hughes was showing you, the long stem with a little round circle at the end of it. What you'll do is you just scrape to the base of it, and then you will use a little cautery and you will cauterize around that area, and you do it like 3 times. So basically you're burning, scraping, you know, to get all of that out. But usually, like I said, they're usually done in smaller lesions. With this, you have a higher risk of recurrence because you don't know if you're really getting at all of it. You're just assuming by going around the borders of it and by scraping deep into the layers, you know, into the dermis. Second option is surgical excision, so you could send them to a general surgeon. Most of the times, if it's on the face, I usually will send them to a plastic surgeon or a head and neck surgeon. Having said that, I wish I had a mole that I had forever on my back. I went to my dermatologist when I was maybe in early college, because my friends freaked me out. They're like, oh my God, you gotta get that mole taken off. And it was big, it hadn't changed, but you know, I was nervous, and I was out in the sun a lot, so I was like, okay. So I go, and she just did a shave excision. So she kind of did with that, you know, blade and cut it off. And remember how Professor Hughes said that sometimes if it's deeper, you'll have a little piece of pigment left behind? That's what she did. So I developed a keloid with a little black dot in the center of it. So she eventually, I think she tried going back again and shaving off the keloid, and then I got injections into the keloid, which those burn like no other. But the keloid, the injections help keep it flat. So now over the time, it's kind of just gotten flat, and you can't hardly really see it as much. But when I was younger, it was red, you know, and inflamed and horrible, and I hated it. You can send them to a Mohs surgeon. So if you send them to a Mohs surgeon, just know that once they see that Mohs surgeon, they're gonna have this, depending upon the size of the lesion again, they'll have a big defect. So you'll wanna send them to either a plastic surgeon, head and neck surgeon, somebody to cover it up once they're done. Because a lot of times, you know, something that may be small, they'll end up having a really big defect. Just because cancers like to have what we call little fingers that spread outside of the actual source of the tumor. So that's why you keep cutting, you keep getting positive margins, and then you get this big giant defect. So it's a big giant wound. Now sometimes you can just treat them with radiation therapy, or you can do it as adjuvant. So if they've had it removed but they don't think they got it all, or have a high risk of recurrence, then I would go ahead and send them for consult for radiation, and they can get several, 2 weeks of radiation. There's a couple of creams that you can use. The first one is Aldara. I don't know if you've ever seen it, so basically it just makes all these little lesions, you put it on your hands and your face and little lesions, and it turns bright red, and then eventually it crusts and falls off. And that's the same with the 5-FU or 5-fluorouracil. And there's a new treatment called Araveg, and that's an oral chemotherapy. So people keep getting recurrent, I think it's basal cells, but I thought you can use it for squamous cells as well. They take this oral chemo to help prevent any new ones from growing, or keep the new ones and make them regress, make them smaller. And for patients who've had a basal cell, or you're really observed periodically for 5 years or longer. So in our world, in head and neck, after 5 years, you're considered cured. But generally, the first year, we see them, but it depends, again, what type of cancer it is and how extensive it is. You can have them followed with their dermatologist every 6 months to a year, or we would see them. So you have a risk of developing a second basal cell within 5 years, or within the 5 years of the first basal cell is 36 to 50%. So within that 5 years, they'll usually have a recurrence. And so if you're watching them, you can catch it early, take it off, and they'll be good to go. So this is a patient who had a basal cell. So it's kind of hard to tell, but she actually had what we call a paramedian forehead flap. So she had all of this basal cell over her head had grown and invaded her nasal cavity, okay? So then when they removed the tumor, she had this big hunk right here that was gone. She just had an empty hole. So in order for them to fill it, they do what's called a paramedian forehead flap. So if you can kind of see, she has a scar. Again, she's white, very fair, so it's hard to see her scar. But what they do is they go in, they cut it open, take a piece of it, like a strip of that, and they turn it over, and they attach it to right here. So this is her forehead skin right here. So they turn it, flip it over, and see, so she's got this little elephant trunk. You can actually put your finger between here, her eye and the skin, the backside of that skin. And that stays attached to her face for about 3 or 4 weeks, I think. And then what they do is they schedule her for another surgery, and she has what we call a takedown. So then what they do is they will cut the connection here and here. And basically they sew this all back up. Because what we're wanting is this tissue that was up here to reanastomosis and get the blood supply before you cut it off. And then you sew her back up. I wish there was one patient we had, it was amazing. He had a Mohs procedure, I think, I can't remember, but it took off like this whole front part of his nose right there, and they did a paramedium forehead flap on him, and if you look at it, it's beautiful. It's like he never even had anything done. It was crazy. That's the only one I still had left over, and she loved me. She hated seeing the doctor. The second most common type that I saw, and actually I feel like in head and neck I saw more squamous cells than I actually did basal cells. But it's called squamous cell carcinoma. So it's the same cell type that is on the skin that we saw in head and neck and the oral pharynx, the tonsils, all the bad stuff on the inside. So it compromises 20% of non-melanoma skin cancers are squamous cells. It's the second most common cancers in Caucasians. But the difference between squamous cells and basal cells, you have a higher risk of metastases. So these little boogers like to grow. They don't like to just sit there for decades and decades. These like to grow. Especially located in areas of thermal energy, so a lot of sun exposure, or people who have had prior radiation. It's just because that strange cell turnover that you have on any traumatized area on your body. Or someone who has chronic ulcers or chronic draining sinuses. So again, like we talked about with people who have hidradenitis suppurativa, same thing, you have this chronic flow, chronic changes in tissue that you can have a squamous cell. Risk factors, UV radiation, early in childhood, again, light hair, light eyes, have had radiation. Those who work outdoors, your farmers, your construction workers, those are all people who are at high risk. And again, those who have immunosuppression. And actually, we had several patients who had been treated for some other type of cancer that they've had chemo, and certain chemos actually give them a risk of having squamous cells. And I can't remember off the top of my head which one that was. But we had a lot of those who come in with recurrent squamous cells. It was actually an old man. I think he had tons of them for some reason. They grew up outside of his ear. Pretty much he had no ear on one side, and then it started growing out of his other ear. Again, with these sun-exposed areas, the most common: scalp, back of hands, the top of the ears, tip of the nose. Again, commonly in older people, just because it's taken so long for that bad skin to rise up to the top. And male to female, same. Males are higher risk. And then precursors are what are called AKs, or actinic keratoses. So again, you'll see these, like, you can feel them if your dad or maybe bald or whatnot. You can actually feel along their skin, and you'll feel like these little rough patches. You may even see what we call cutaneous horns. Almost looks like little horns that grow out of their skin. Old people, you'll see them. You sit and you'll be at Denny's or something one day, and you'll see all these little things that poke up. But that's how I usually feel them, is you can feel them on their scalp. It just feels like rough little thin. It's usually kind of yellowish in color, spots on their face and their hands. And those are things you need to send them to the dermatologist, or you need to freeze them off, because those will eventually turn into squamous cells. The AKs will. Pathophysiology, so basically atypical squamous cells, or from proliferating keratinocytes. And what do these things look like? How does one present to your office? So usually they will have a shallow ulcer, or they'll just say, again, I've had this spot on my arm that I keep picking at it and it flakes off, but then it keeps growing back, or it bleeds every time I shave, you know, those kinds of things are what you're looking for. And a lot of these squamous cells are ulcers, so it's mainly a sore that won't heal. And often, like I said, it's covered with a plaque that they pick off, and then it re-epithelializes, and then it scrapes off in the same same. Now, I don't really, it says red, soft, freely mobile tumor with an inflamed base. I really don't see that often. I see more of the superficial ones that are just kind of flat. They have a scale that's thick and adherent. So these are squamous cells. So these are a little bit more aggressive, they're more ugly looking. This patient, I had one patient who had a squamous cell, it was a lady. She actually had it on, just like on the inside of her vermilion border, like right there at the corner of her mouth. And literally 2 weeks later, I saw her, it looked like this. So they grow really rapidly. And unfortunately, sometimes you just see someone that has it, it may take 3 or 4 weeks for you to get in to see a surgeon or have surgery with the surgeon to remove it, and it will unfortunately grow at that time. But you just have to tell the patient, you know, I know it's growing, but we'll get it out, you know, as soon as we can. So we saw a lot of lip cancers, lower lip, again, just because it protrudes out. So the sun hits your lower lip, usually on the vermilion border. Tip of the nose, medial canthus. We had one patient, it was like, we literally removed, I think he had surgery to remove one right there, medial canthus, and then I can't remember if we had done his paramedian flap, I don't remember, but I remember he came in just for a follow-up, and I saw a red nodule right there, and I was like, son of a gun. Because usually, you know, they won't like to reconstruct them until they get free margins, or they know that cancer is gone, because you flap it, it grows back, you've just done work for no reason. And sure enough, when he was there, I went ahead and biopsied it, and it came back as a squamous cell. So he already had a rapid reoccurrence between the time he had it removed and the time he had reconstruction.
Is that painful?
Yes. The sores, your patients will complain of pain, that, you know, that it hurts, kind of aches. But these around the eyes do, just because they also pull down on your eye. But yeah, these sores will hurt. Tip of the nose, the lips one really do hurt the most because you have so many nerve endings in your lip. So imagine if you bite your lip, how bad it hurts. So imagine something that's basically just eating away at your lip. It really hurts. So metastatic potential depending upon the location, the size, the degree of differentiation. So again, that would be mainly you would see on pathology, how one would be more aggressive than the other. It depends on the patient's immune status. And then evidence of what we call perineural involvement. So a lot of our patients will have tumors that will be on like their cheek, that will involve their facial nerve. So we will call that perineural involvement, and a lot of times you have to sacrifice that nerve to get the tumor out. So then they end up with a paralysis of their face. But again, you can send them to the head and neck surgeon. They can do what's called reanimation. They put a sling in, they oversling it to make them look like they smile. So that eventually when it relaxes, it'll close their lip. You know, you want to overdo it rather than underdo it, because it'll eventually get lax and it'll drop. Highest risk of occurrence, so the highest risk of metastases is on the scalp, the ears, lip, nose, and forehead. The reason why is your lymphatic system drains downward. So a lot of times people may have, and you know, we see this a lot in our patients who have, or have had like let's say an SEC on their scalp, and then like a year later or 6 months later, they come to our office because they've got a lymph node that's swollen in this neck. You biopsy and it's a squamous cell. So squamous cells, in any type of cell actually inside a lymph node, is usually not a primary source, especially if it's a squamous cell. So it eventually came from somewhere. And normally if it's here, we assume that it came somewhere up north. So they may have had some residual cells that traveled into the lymphatics and got down into the lymph nodes in their neck. Ears, lips, like I said, the lips can metastasize deep into the mucosa, down to the floor of mouth, into the gingiva. The nose, they like to metastasize and go deep down into the maxilla. And these are again, just differential diagnoses, what they kind of look like, AKs, SKs. And I think Dr. Allen's gonna talk to you all about seborrheic keratoses unless no one's done that lecture yet, right? Okay.